Well, good afternoon, ladies and gentlemen. It's my very great pleasure to welcome you to this Garfield Atrial Fibrillation Satellite Symposium here at the European Society of Cardiology. At the outset, I'd like to thank all of the faculty for today's meeting, all of our investigators spread throughout the world at over 1,000 sites, and in particular all of the patients who have given consent for their data to be entered into this registry for us to follow their clinical course and therefore develop some of the insights that we're able to share with you today. I'd also like to thank Bayer for their continued support through an independent research grant for this registry, which has allowed us to create one of the most interesting and exciting pieces of research in the field of atrial fibrillation. I'm AJ Kakkar from London, and I have the privilege of chairing the steering committee. Before we proceed, I just want you to spend a moment studying my disclosures. And I just wish to take a few moments at the beginning of this symposium to remind colleagues about the GARFIELD-AF registry. It's currently the largest prospective atrial fibrillation registry in the world. We've been, through a remarkable collaboration in some 35 countries, over 1,000 representative sites, have been able to bring together some 52,000 newly diagnosed and prospectively followed patients with atrial fibrillation. The total recruitment is some 57,000 patients because with our particular design of 5 sequential prospective cohorts, the first cohort allowed us also to take a group of patients from sites who had been previously diagnosed and prospectively followed to try and determine how participation in a registry might impact on behavior of clinicians and the way that the patients are subsequently managed. With the sequential cohort design, we've been able to follow patients for a minimum of 2 and up to 8 years, and that has therefore provided us with unique insights into how patients with atrial fibrillation, irrespective of how they're measured, are managed, perform over a long period of time. These are the 35 countries that have participated in the registry, and you can see here how we've collected data since 2010. The first cohort collecting over a slightly longer period, and thereafter recruitment of patients in each cohort, some 10,000 patients, taking about a year, and we now being at the stage where we are just completing follow-up for the minimum of 2 years on the last cohort of patients, cohort number 5. And what's interesting in this particular type of design is to be able to look at treatment trends over time. So if one looks at patients in cohort 1 and compares those to cohort 5 in terms of baseline intervention for anticoagulation in patients with newly diagnosed atrial fibrillation, one can see at the outset of this registry in 35 countries around the world, some 57% of patients received some form of anticoagulation at baseline with newly diagnosed atrial fibrillation. You can see that the blue bars or blue elements of the bar represent vitamin K antagonists, the red, the novel oral anticoagulants, the green antiplatelet therapy alone, and purple no intervention. And you can see over time how there has been a substantial increase in the use of anticoagulation from some 57% of patients, as I say, in cohort 1, to 71% of patients receiving baseline intervention by cohort 5 with some form of anticoagulation, and the substantial uptake across the world of the novel oral anticoagulants, some 4.2% in 2010, over 40% of those commencing anticoagulation in the 2015-16 inclusion cohort. This has been at the expense of vitamin K antagonists and, to an extent, the use of antiplatelet therapy alone. What's striking is the consistent non-use of any intervention in about 10% of patients. Now, if we look at the incident rates for various outcomes in these prospectively followed patients, some 52,000 across the 5 cohorts, one can see that the greatest burden, something that we're going to further focus on in this symposium, is the risk of dying, with an event rate of 4.3 per 100 person years for all-cause mortality. You can see the rates for cardiovascular and non-cardiovascular death, stroke and systemic embolism rates of 1.36 per 100 person years, major bleeding 0.85. But what's striking are the other manifestations of poor clinical outcome in these newly diagnosed AF patients within a year of diagnosis. Acute coronary syndromes at 0.79 per 100 person years, and what's striking is new episodes of congestive heart failure, some 2.2 per 100 person years. If one looks in the first year follow-up at these 52,000 patients and looks at the causes of cardiovascular death, one can see that congestive heart failure makes an important contribution, sudden death, myocardial infarction, with ischemic stroke as only the 4th cause of cardiovascular death in newly diagnosed AF patients. One can also see that there is a substantial burden of non-cardiovascular death in that first year after diagnosis with atrial fibrillation, with death from malignant disease and infection being particularly prevalent. If one looks at the nature of strokes in these patients, one can see that ischemic stroke represents an important proportion of all stroke burden, with intracerebral hemorrhage representing a much smaller proportion of the burden of stroke in patients with newly diagnosed atrial fibrillation. What we've seen is we've been in the privileged position of being able to analyze the data and interpret the data provided in the registry, is an increasing understanding that comorbidities drive poor outcome in patients with newly diagnosed atrial fibrillation, and therefore an integrated approach to the care of these patients, focusing not only on anticoagulation, but looking, for instance, at better management of other comorbid conditions, particularly, as we'll see in this symposium, the impact of comorbidities such as chronic kidney disease, such as heart failure, such as previous stroke, or TIA, such as stable arterial disease, having an important impact on poor outcome, means that as we move forward and try to understand how to achieve the very best for patients presenting with atrial fibrillation, we might give further consideration to how integrated care might address improved management of these important comorbid conditions. Today we're going to look at principally data for the entire 5 cohorts at 1 year, and that will be the basis of the majority of analysis, but we will also see data with regard to 2-year outcomes for these newly diagnosed patients with atrial fibrillation. And each of the speakers will let you know exactly which data sets they are using. The particular focus is to understand how comorbidities impact on prognosis for patients with atrial fibrillation, and therefore to appreciate how comprehensive management strategies could further impact on improved clinical outcomes for these large numbers of patients throughout the world. It's now my very great pleasure to call upon Dr. Sam Goldhaber, who's going to talk to us about burden, the morbidity and mortality associated with AF. Thank you very much indeed.